Good afternoon. I'm going to read the ITP guideline. I'm trying to pick the most important guidelines that comes up in the exam and focus on it. Okay, so immunothrombocytopenic purpura, the definition. Platelets less than 100 multiplied by 10 power 9 per liter, usually less than 20 multiplied by 10 power 9 per liter. Okay, so basically it should be less than 100, but usually it goes down below 20. Self-limiting disease with shortened platelet survival and increased megakaryocytes. Good prognosis. We have three types of ITP. We have acute and persistent and chronic. Acute lasts from 0 to 3 months. Persistent ITP from 3 months up to 12 months. Chronic ITP lasts more than 12 months. So we have three types, whether acute, persistent, or chronic. Acute up to 3 months, persistent from 3 months to 12 months, chronic more than 12 months. Symptoms and signs. It's going to be acute onset bruising, purpura and petechiae, serious mucosal bleeding, unusual. Look for other causes. It may be preceded with infection, absence of hepatosplenomegaly, lymphadenopathy, evidence of serious cause or chronic underlying illness. So we should rule out any organomegaly or lymphadenopathy because it's one of the differential diagnoses of leukemia. So we have to rule out this stuff. Investigations, full blood count, blood film and clotting, blood group, if headache and or neurological signs, urgent CT scan of head, bone marrow aspiration unnecessary unless there is neutropenia or severe anemia, hepatosplenomegaly, lymphadenopathy, pallor and lassitude, pain, limb or abdomen or back, limbing. We have to do okay, so again, the investigations, we said it's necessary to do full blood count, blood film and clotting, blood group, if headache and or neurological signs, urgent CT scan of head, bone marrow aspiration necessary unless there is a neutropenia or severe anemia, hepatosplenomegaly, lymphadenopathy, pallor and lassitude, pain, limb or abdominal pain or back pain, there is a limbing. We need to do cytomegalovirus and Epstein-Barr virus, IgM as well. If risk factors, HIV and hepatitis B and C. So we have to do after taking a consent, HIV, hepatitis B and C, immediate treatment. None regardless of platelet count unless life-threatening owing to significant bleeding. If significant bleeding, for example, uncontrollable epistaxis, gastrointestinal hemorrhage, intracranial bleed, give platelet along with methylprednisolone. So So basically, there's no treatment to be given regardless of the platelet number, unless there's life-threatening bleeding or significant bleeding. If there is a significant bleeding, which is like uncontrolled epistaxis, gastrointestinal hemorrhage, there is intracranial bleeding. So in this situation, you will give platelets along with methylprednisolone, 30 milligram per kg per day by IV infusion up to 3 days, or immunoglobulin 0.8 to 1 gram per kg can be repeated once within 3 days if required. Red indication in the demand management program of immunoglobulin. Okay, so if we have significant bleeding, we will give platelet altogether with methylprednisolone or platelet with IVIG. Okay, what if we have a moderate bleeding? For example, prolonged mucosal bleed. In this situation, you will give prednisolone 2 milligram per kg per day up to 14 days, then taper over 21 days. Okay, or prednisolone 4 milligram per kg per day for 4 days, or immunoglobulin 0.8 gram per kg IV single dose. So in cases of moderate bleeding, for example, we have a mucosal bleeding, but it's taking more longer, you will give prednisolone 2 milligram per kg per day for 14 days, and you start tapering over 21 days, or instead you can give prednisolone 4 milligram per kg per day for 4 days, or instead you give IVIG 0.8 gram per kg IV single dose. Consider tranexamic acid for small bleeds. Avoid non-steroidal anti-inflammatory drugs, for example, ibuprofen. It's contraindicated in cases of ITP. Reassure parents. Discuss newly diagnosed ITP with pediatric hematologist or pediatric consultant with a hematology interest. Discuss treatment with platelets with pediatric hematologist in event of essential operations, emergency dental extractions. So that's the immediate treatment or management of ITP in brief. We have significant bleed, we will give platelet altogether with methylprednisolone or platelet with IVIG. So platelet with methylprednisolone for 3 days, platelet with immunoglobulin can be repeated once within 3 days if required. If you got moderate bleeding, so in this situation you will give either prednisolone 2 milligram per kg per day for 14 days and tapering over the next 21 days, or you can give prednisolone 4 milligram per kg per day for 4 days, or instead you give a single dose IVIG 0.8 gram per kg. If you have a minor bleed, you give tranexamic acid only. You advise avoiding the non-steroidal anti-inflammatory drugs like ibuprofen. Reassure parents. You discuss the newly diagnosed cases with the pediatric hematologist or pediatric consultant with interest in hematology. If you need to give platelet, you have to discuss with the pediatric hematologist before dental extraction or any major operations. Okay, what's the subsequent management in cases of ITP? So subsequent management is very crucial and important. About 75 to 80% resolve in 6 months. So some cases take 6 months to resolve completely, 75 to 80%. Favorable outcome irrespective of treatment. Avoid contact sport during this time, and possible to prevent fighting, rigorous knockabout games at home. Parents can find additional information from ITP Support Association. This is a link over here for a support group or ITP support associations. They collect donations and they support those patients. Let's move to the next page. We have monitoring treatment. How you gonna monitor the treatment once you started it? So you will monitor by doing a full blood count and film monthly until the diagnosis is clear or recovery. So full blood count and blood film every month until recovery or diagnosis is clear. Repeat sooner if bleeding or increased bruising. Okay, what's about the discharge and follow-up? Discharge from long-term follow-up when platelets more than 100 multiplied by 10 power 9 per liter and asymptomatic. So once the platelet count goes up more than 100 and the patient is asymptomatic, so you can discharge and you can follow up in the outpatient clinic. Advice of risk of relapse. The risk of relapse is about 20%. You have to be transparent and clear with the parents, and you have to tell them that there is a risk for relapse. So they have to be careful and they have to be to know how to spot it. Note that mothers with history of ITP, even if they have a normal platelet count, can give birth to thrombocytopenic babies. So moms who have a history of ITP, even if their platelet count is normal, the baby or the newborn baby can be thrombocytopenic at the time of birth. So it's very important to keep this in mind. It's very important. Okay. Okay, what's about the chronic immune thrombocytopenic purpura? People who have a chronicity that lasts more than 12 months, which means that lasts more than 1 year, so they have to avoid the non-steroidal anti-inflammatory drugs. They have to avoid a contact sport. They have to avoid the contact sport, investigate for autoimmune disease. For example, like anti-nuclear antibodies, anti-phospholipid antibodies, anti-cardiolipin antibody, and lac lupus anticoagulant, and immune deficiency, HIV, IgG, IgA, IgM. Treat only profound thrombocytopenia less than 10 multiplied by 10 power 9 per liter with repeated mucosal bleeding. Older girls with menorrhagia, trauma, acute neurological signs. If treatment indicated, give prednisolone 2 mg per kg per day for 14 days, then taper over the next 21 day, or dexamethasone 0.6 mg per kg per day orally for 4 days if ongoing bleeding. Must have bone marrow aspirate before treatment. So it's very important to rule out leukemia by doing a bone marrow aspiration before starting the treatment or by dexamethasone. If unresponsive, discuss with pediatric hematologist about the treatment with rituximab or thrombopoietin receptor agonist. Thrombopoietin receptor agonist. And this is very important, how you go step by step in your management of chronic ITP. Splenectomy reserved for those with persistent or significant bleeding, non-responsive or intolerant of other therapies. So again, patients with chronic immune thrombocytopenic purpura, they should avoid non-steroidal anti-inflammatory drugs, avoid contact sport, investigate autoimmune diseases, looking for antinuclear antibodies, antiphospholipid antibodies, anticardiolipin antibodies, lupus anticoagulant, and immune deficiency diseases which may be associated with manifestations and symptoms indicating for mimic the chronic ITP, such as HIV. You check the IgG, IgA, and IgM, immunoglobulin assay. You will need to treat only if there's a profound thrombocytopenia that's less than 10,000 with repeated mucosal bleed. So you will have to think about starting treatment. Older girls with menorrhagia, they need, of course, treatment. Trauma, acute neurological signs. If treatment indicated, so what kind of treatment you will give in case of chronic ITP? Prednisolone 2 mg per kg per day for 14 days and will taper over the next 21 days. That's the first thing to do. Dexamethasone 0.6 mg per kg per day orally for 4 days if ongoing bleeding. Okay, and before that you have to do bone marrow aspiration before starting the dexamethasone. Okay, let me highlight those so we can remember the colors later on. Okay, if unresponsive to treatment, discuss with pediatric hematologist about rituximab and thrombopoietin receptor agonist. Last but not least, a splenectomy is reserved to the at the end, reserved for those with persistent or significant bleeding, non-responsive, or intolerant to of other therapies. So that's the ITP guideline. We have finished it. I hope you enjoyed it and you get benefit from it. Please like and subscribe for my channel if you don't do so for more guideline videos in the future. Thank you.